channel. I hope you are all doing great. I know it's been a long time since I uploaded my last video. So here we are, and today we are going to discuss an important topic of inborn errors of metabolism. So these are a group of disorders which constitute many diseases. So let's get started. So today we will learn about to define the inborn errors of metabolism, importance of screening tests, and to know the principle of various screening tests done to detect suspected cases. We are concerned to our subject, that is lab medicine, and different screening tests and diagnostic tests used for diagnosing these group of disorders. So first of all, metabolism. So every metabolic processes constitute many chemical reactions that occur in the living cell. They can be anabolism or catabolism. So there are two types of processes, anabolism and catabolism. Anabolism means making up things, building blocks, and catabolism means destroying things. The metabolic pathways, these are a series of enzymes controlled reactions leading to the formation of a product. Means many enzymes or many substrates, intermediates form to finally form a product. And each new substrate is the product of the previous reaction. Now, inborn errors of metabolism. These are the disorders due to impaired activity of enzymes or cofactors that result in accumulation of substrates or lack of necessary products. Means, for example, A forms B in the presence of enzyme A, and B forms C in the presence of enzyme B. If suppose enzyme A is defective or enzyme A is not formed, then B cannot form, so there is accumulation of A. And same way, if B is not formed, C will not be formed. Anyways, enzyme B will be present in the body, but C will not form. So it is also a inborn error of metabolism. And C forms D in the presence of enzyme C. Also, C can form E, E to F, like that. So these are a series of reactions performed with the help of various enzymes. So these inborn errors of metabolism are rare in occurrence. Let me change the pen. These are rare in occurrence and they are detected most frequently at infancy. Early treatment and diagnosis is a key factor in managing these conditions, because if we detect or diagnose them at a later stage of life, they cannot be treated accurately. Now, if untreated, can commonly cause irreversible damage to the nervous system. And these are some of these diseases are very fatal at an early age. So, irreversible damage to the nervous system. It can be due to accumulation of neurotoxic metabolites, or deficiency of certain product will decrease the synthesis of neurotransmitter in the brain and the spinal cord. In these patients, the blood-brain barrier is also poorly developed. Now let's talk about screening. I hope you all remember your PSM. In that, the early diagnosis and appropriate treatment can help alleviate the symptoms. I told you earlier also. And early diagnosis can be achieved by the screening test, which are very, very important in diagnosis. So this point is the disease onset, and this point is the first possible detection of the disease. This point shows the final critical point of diagnosis, and this point shows the usual time of diagnosis. So up to the usual time of diagnosis and then the outcome. So we have two scenarios, A and B. So in A, the time period between the first possible detection of time and the final critical point of time is known as screening time. Please remember, this is very important. The screening time is the time between final critical point and the first possible detection. And the lead time. Lead time is the first possible point of detection to the usual time of diagnosis. So if we screen disease early, then we have a better outcome. And if we do not screen the disease early, then it will be diagnosed at the usual time of the diagnosis, or screened at the usual time of diagnosis. Then the outcome will be poor comparatively. So in community also, this plays a very important role in detecting many diseases like diabetes. Now let's move on to the next slide. So screening test and diagnostic test. So differences between these two. So screening test is apparently healthy one, and diagnostic test is sick or with overt indications. So these type of tests are done in sick patients. Now screening test is more sensitive and less specific, and diagnostic test is more specific. Screening test can results. The results of screening test are only hints, and diagnostic tests are definitive. The positive result of a screening test is not a basis for the treatment process to start, and diagnostic test is positive, means it is a basis for treatment. A screening test is mainly economical, and diagnostic test is comparatively expensive. Now, different classes of inborn errors of metabolism. So first is amino acid opathies. In this we have example of phenylketonuria. Urea cycle defects, we have citrullinemia. Organic acidemias, alkaptonuria, disorder of sugar metabolism like galactosemia and G6PD deficiency. So today we will discuss an important disease of phenylketonuria. So it is the most common inborn error of metabolism. The prevalence is approx 1 in 10,000 to 20,000 births. In this, the accumulation of phenylalanine and its metabolites occur. It arises from the defect in phenylalanine hydroxylase. So it's the enzyme which is very crucial. It arises from the defects in the phenylalanine hydroxylase, known as classic phenylketonuria, or it can be dihydrobiopterin reductase enzyme deficiency or dihydrobiopterin biosynthesis defect. It is an autosomal recessive inheritance. So the main symptoms can be mental retardation, hypopigmentation, increased tyrosine in diet, mousy odor of urine, seizures can occur, eczema on skin, and it is an autosomal recessive, or in urine it can lead to increase in the phenylketones. Now this picture shows the metabolism of phenylalanine. So actually the dihydropterin is formed by the L-phenylalanine in the presence of phenylalanine hydroxylase, and this dihydropterin is reduced to tetrahydrobiopterin by the presence of dihydropterin reductase with the help of NADPH into NADPS, NADP plus. And this L-phenylalanine also converts into L-tyrosine. So you can get an idea that if we give the patient phenylalanine more in the diet, it will surely not gonna help. And if we give tyrosine in the diet, it will surely help the patient, because tyrosine is not forming because defect in phenylalanine hydroxylase. So the screening tests for phenylketonuria, first is Guthrie bacterial inhibition test. So in this, the Bacillus subtilis is used, and it requires phenylalanine for growth in culture. So in presence of phenylalanine antagonist, if we give beta 2 thionylalanine in culture media, bacterial stops growing. Now bacteria stops growing in the presence of beta 2 phenylalanine. Now if we take blood from a normal infant, there is no growth of bacteria, and blood from phenylketonuria patient is added, then the bacteria proliferates in phenylalanine, is not metabolized, and it is present in high amounts. I hope you are getting the important points. Now this picture shows the Guthrie test. In this we have Bacillus subtilis, beta 2 phenylalanine, and phenylalanine increases the growth if it is present. This shows the explanation for the previous slide. Now second one is ferric chloride test. In this we take 5 ml of fresh urine sample, and we add 3-4 drops of ferric chloride solution. If phenyl pyruvate is present, then it gives green blue color. And third one is dinitrophenylhydrazine DNPH test. In this we take 2 ml of urine and add an equal amount of DNPH reagent and mix. So we wait for 10 minutes. Appearance of yellow precipitate implies the presence of keto acids like phenyl pyruvate. In this we also the presence of yellow precipitate shows the presence of phenyl pyruvate. So guys, this is for today, and we will continue our this topic of inborn error of metabolism in upcoming days. And up till then, please like, share and comment on which topic you want further videos. Up till then, bye bye, take care and keep studying.